Hello and welcome to Cutting Edge Pain Relief. Today we are going to be talking with two gentlemen who know their stuff. What our discussion today is going to be about is pain relief for back pain that many people have using percutaneous PNS medial branch nerves. And I know that's a mouthful. I know that sounds fancy as heck, but we have two gentlemen who are going to be able to break it down for you to understand about a back pain treatment option, which is minimally invasive, doesn't require us going into the epidural space, that can be sustainable and provide relief that is substantial and significant. And so I am blessed to have both Rams as well as Tyler here with us today. I think Rams may have muted himself at the moment to prevent us from getting all of that full understanding that he's about to deliver to us. But I want to make sure that you guys are here with us. Rams, Tyler, can you hear us?
I can hear you perfect. Can you hear me?
Thanks for having us.
Okay. Thank you for being here. I really do appreciate it. And can you guys tell me what company you guys are with?
I'll take the lead on it. So myself and Tyler support everything Stim Router. So Stim Router is the product, and Bioness is the name of the company.
Okay. So that being the case, if we were really kind of taking a look at it, I would imagine that this is probably what you're referring to. Is that right?
That is the Stim Router.
All right. So I think you guys are going to give us kind of a full-blown, detailed PowerPoint, like fancy discussion about it, right? But before we kind of get into all of that, I want to have us have a conversation about some other things first, if that's okay.
Absolutely.
Sounds great.
All right. Sounds cool. So I know that we already have people joining us, and I appreciate everyone who's joining with us live right now. As you guys know, this will also be evergreen content that'll be found on our YouTube channel. And I can tell we even have canine like people giving us props up. So we appreciate that. But what I want to do first is talk a little bit about back pain and explicitly what are the areas that we're targeting for this so that everyone's on the same page. And as you know, we're going to break it down so people understand exactly what it is that's going on. So all the fancy lingo is not too highbrow and you can understand exactly what it is that we're talking about. So what we're talking about dealing with is probably one of the most common causes of back pain, and that's dealing with something that's called a facet joint. So the facet joint are the joints that connect the posterior elements, if I was using language like Rams will soon use, that talks about how the spine connects, right? It's that flexible area that allows for things to be able to move. So if you can see this joint capsule has the ability to be able to allow for you to be able to turn, bend, and move. Exactly. I agree with the bark. That's exactly right. We're going to be able to bend, twist, and turn. And what we have in place in the front portion is the vertebral body and the intervertebral disc. And in between all of this sits the spinal cord and nerves. So as I can clearly see, I'm getting some encouragement to move along. So what I'm going to do is kind of show you guys exactly what we're talking about in a couple different levels and move through this pretty quickly. But we're going to be targeting these joints that frequently are known for causing back arthritis. So that facet joint is this joint here, different from this nerve root, which comes out through something that's called a foramina. It lets us bend and twist and turn. It's present throughout the areas of the lumbar spine, the thoracic spine, and the cervical spine. So those areas are located in the low back, the mid back, and the upper back. All right. When we take a look and we look at this in depth and detail, it again is what lets you be able to bend backwards and be able to bend forward. Those facets are critical. So for many patients, when they come in, they say, you know what? I have pain, and I have pain particularly when I bend and when I twist. If they're a gardener, a golfer, a construction worker, they like to be able to do a number of physical activities. It will give them a problem when they first get up in the morning. It gives a lot of different challenges and issues that really historically are difficult to treat. What many people will do is to try to use a leave or naproxen for a period of time. They'll try to use some heat. But then sometimes they'll end up coming to someone like myself, right? And we'll talk, oh, well, I think what we can do is to do something that's called a medial branch block. And as many people know, that is utilizing some formulations of heat. Now, my patients know that the aspect of burning nerves, as they would actually qualify that radio frequency, is like fingernails on a chalkboard with a certain actress that has a high-pitched voice, all put in combination like Rosie Perez. I really hate that description of burning nerves, but there is an application of heat that stuns the nerves. But be that as it may, that's not what we're talking about. But let me show you, because people frequently feel like, why would I want my nerves burned? That would be the last thing I would want. So let me show you exactly what we're talking about. So when you take a look at this picture, you can see the big nerve that comes out that supplies the areas of the aspect of different parts of the limbs and truncal regions and muscles. But then there's, if you would, a small little tributary that comes out and actually innervates the joint. Its main role is to predominantly give sensation to that joint. Now, it does do a few other things, which are actually kind of important, and is one of the reasons the technology we're going to talk about in a few minutes is really so sexy, because we're not affecting that nerve in a way that's going to be harmful to the rest of the body. And so what that nerve also does is it supplies a muscle called the multifidus. And that muscle that's called a multifidus, it's huge in terms of being able to provide support to the back. And traditionally, when we do radiofrequency ablation, it can cause different problems accordingly. So when we take a look, we can see that nerve root that's over here that's supplying the joints, which is different than the big nerve root that is actually going to supply the muscles, which is a different thought process. But still, nonetheless, that small nerve root can cause a lot of problems for what is entailed for its size. So again, we take another picture and look, we can see the small little nerve root supplying the joint, the big nerve roots going someplace else. And I think you guys kind of got it now. I'm really just belaboring the point and being a little bit of a teaching doctor jerk, but bear with me for one more picture. This one you're going to see shows a lot of stuff. So this one has all these different nerve roots coming out, but now you know what it is, right? It's really supplying the aspect of the joint so that you can have sensation when you're bending and twisting, proprioception, if you would, and it really supplies some degree of pain. But when we apply heat, not burn, we apply heat to the nerve, it can be able to stun it. So what does that look like? Well, if you were to take a quick picture, it looks something like this. You have a special type of needle that's coming in. You have a different needle inside of a needle, and that needle applies heat that can then be able to stun the nerve. But how long does that stunning last for? That's really the question, as my guys are sitting here like, man, he is just going to go on and on. It's 8 minutes already. But normally, it doesn't last all that long as much as what we want. Do we do this in our office? We certainly do. It can be able to provide some degree of relief, but typically it's limited anywhere from maybe 6 to 9 months, right? So is there a way to be able to make it last longer? Yeah, of course there are. So there are things like this, which is an endoscopic rhizotomy, where we go down and we make a small little incision and we use a camera to approach it and see all of the different small nerve roots like I showed you in those pictures, but we can actually visibly see them so we can be able to get a much more robust treatment option. But not everybody wants something like that, right? Sometimes people are like, well, do I really want to go after that without being able to having to have that amount of depth and detail? I think we have one of our guests making a quick commentary / question, which is Jesse, and is saying diagrams do shed light on the topic and explains a lot. So I really appreciate that commentary. Thank you so much. And that's exactly what we want to do. We want to be able to explain this so that you can understand it. And as you know, on this channel, Cutting Edge Pain Relief, basically we want to be able to help you punch pain in the face and get back to leading the life that you deserve. So when we get into this and we talk about endoscopic rhizotomy and we say we're going to make this type of evaluation with the scope and go through all these challenges and provide local anesthetic and maybe some degree of MAC anesthesia, all of those things become really, really involved. And at the end of the day, what if you could get back relief, back pain relief, and you didn't have to do any of that? That's where these two guys come in. So I'm going to let them tell you a little bit about this revolutionary treatment option that they have that can be able to provide pain relief in a different context. I'm going to be quiet now. As you guys have gotten a sense of what facet is, Rams and Tyler, you mind jumping in and telling us a little bit about this new type of technique where it comes from, and also what is the treatment that Bioness is being able to provide that actually has utility outside of the back as well.
Yeah, absolutely. Dr. Landry, can you hear me okay?
I can hear you perfectly. Don't get scared. I'm just going to pull away and let you guys be the star of the show.
I will go ahead and take the lead, and I'll also take the blame for Tyler's dog. Anytime he knows I'm around or hears my voice, he usually makes a run for me. So I'll take the heat for that one. Myself and Tyler support everything stim router. So we'll kind of spend just a couple minutes kind of going to exactly what stim router is, and to kind of give a general scope of how it can help patients with a variety of different pain, and then we'll try to break it down and really go into the details specifically, going into how we stimulate what we call the medial branch area to help specifically with some of that low back pain. Okay. I did work on the spinal cord stimulation world a little bit as well. So if anyone has any questions between something like this and peripheral nerve stimulation, I'll try to give the most unbiased answer I physically can. But any type of questions or anything, I know I talk fast too. I spent a couple years in Chicago, and then they forced me to do so. So if anyone has any questions, feel free to let me know too. Cool.
Rams, don't talk about Chicago. All right. So go ahead and continue.
Hey, side note. I heard something. Someone was supposed to go to the Bears but said no. I'll Google it while it's Tyler's part.
Rams, this is evergreen content, so we're saving this. So when your Lions don't do as well as you expect, we will reflect back on this video and we will have a conversation. All right. Anyway, we're going to get back onto the commentary so our actual guests and watchers can get something substantive other than them knowing that Chicago Bears are a preeminent team. Anyway, so I'm going to let you get back to Bioness and stim router.
Can they see a couple of those slides, Dr. Landrum? Perfect. Okay, so this is probably my favorite slide, my favorite little picture that Bioness creates. If people can take a look at this, what you'll see in yellow is the nerve itself, okay? Then you'll see what looks like a little spaghetti noodle wire. Half of it, there's a little part that's highlighted by blue that's sitting next to the nerve. And then there's a little anchor there that actually keeps that little wire in place. And where you see that blue little kind of signal diagram is where we're stimulating the peripheral nerve. So the stim router is used to stimulate any peripheral nerve outside the craniofacial area. And all we mean by that is outside of kind of the head. Okay. So the only thing that we can't technically do are things for migraines and things like that. So we can stimulate any peripheral nerve outside the spinal cord, including anything in the shoulder per se. So if someone has shoulder pain and has, there's a couple different nerves in that area that we can stimulate. If someone has knee pain, there's a couple different nerves in that area called the saphenous nerve. You probably heard these terms possibly. The genicular nerves. If you've got foot pain, there's a couple nerves down there called the tibial nerve and the peroneal nerve, the sural nerve. If someone's had post hernia, there's another nerve there that can help stimulate and help manage that pain. We do some stuff for like post amputee, the sciatic nerve in the back of the leg. Really any nerve that you've ever gotten a diagnostic nerve block to, or you can do an ablation to, you can technically stimulate the nerve utilizing the stim router. Okay. So to go back to our little diagram, that little yellow is the nerve. Then you've got the lead sitting right next to it. And then the other part of the lead, which is kind of the other end of it, just sits right underneath the skin. And then you have a little sticker, and that sticker talks and sends a signal to the internal lead. It sends that signal wirelessly and then stimulates the lead that's sitting next to the nerve. So whenever you want to turn on the stimulation, and it's completely up to the patient and how often they have pain and how often they turn it on, they can go ahead and put the little sticker on, and I'll show you on my arms here. This is just a little sample sticker. So if I had one for my hands, you would go ahead, put the sticker on your arm. You would have a little remote control, and this remote control would talk to my little sticker here, and it would send the signal down to the nerve that is causing my pain. The procedure is usually done with a single little poke incision. It's a very non-invasive procedure. It's kind of designed in that way. Once you actually have the lead implanted, this is just a demo lead that I have in front of me. It literally feels like a wet spaghetti noodle. It's got that same little anchor that we talked about to keep it in place, and it's kind of has a lot of plasticity to it. I was talking to one of my physicians, and he was asking me the best thing about the device, and I was giving him all these things, and he's like, no. He's like, that's not it. I was like, well, what is it? He's like, it's the flexibility of your lead. Once it's implanted, you really don't feel that it's in there anymore. So whether you put it in the hand or the back or anywhere in the body, you really don't know that it's there, and it's all done with a single little poke incision. So if we can go right to the next slide, this will just show you a quick little overview of the different components that we just talked about. Next slide. Perfect. That little lead's 15 centimeters. It's soft. It's flexible, and then these are just the little external components that go alongside with it. Next slide. These are just, again, the different type of indications. Really, any nerve that is causing pain in a specific area, like the knee, the foot, the hip, specific areas in the back, the shoulder, you can stimulate nerves in those areas and really help manage the pain in a way that's very non-invasive.
I'm sorry, Rams. Indications? What
I'm sorry. Any reasons that you might be having the pain, whether it's trauma or you've had a procedure in the past that maybe the nerve was bothered, or you've had an accident in the past, or we've even worked with patients that have had strokes in the past and certain nerves have been bothered. Anything that is bothering that specific nerve, and we know that the pain is coming from that nerve, we can go ahead and stimulate that nerve. Better?
Can I interrupt for just a quick second?
Absolutely.
Perfect. Even for a Detroit Lion fan. I'm just kidding. So I do have some questions coming in, and we want to make sure that they're getting asked. And so one person asked, and I think you kind of covered this, but still nonetheless, we want to make sure. Yeah. What about for the hips? Can you do something for the hips?
For sure. So a couple different nerves there. Actually, we just did one that was kind of a combo. So I'm going to throw out names of nerves. You can ignore them. Obviously, Dr. Landrum's job is to identify which nerve, but there is a lateral femoral cutaneous nerve there, and then a femoral nerve that is there. We do a lot of those. With I would even say, Tyler, correct me if you think I'm saying anything wrong, I would even say above average results. Our usual pain relief is anywhere from that, I'd say 50 to 65% pain relief while you're utilizing the stim router. I would say for the hip, for whatever reason, maybe those nerves are a little bit more visual under ultrasound, a little bit easier to quantify and to see. But those average results have been in the 70 percentiles, at least for our patient population. So absolutely for the hip, with some really cool results.
All right. I know we're talking about back pain, and that's what we're going to really get into about this new kind of utilization that both you and Tyler are going to kind of jump on. However, we have another question that's coming on and another question after that. And so I just love it when we have people who are engaged and asking questions that really are interested. And so we're going to just jump straight to the questions so people don't come to my office and then come do something to me. So I want to make sure that people are getting their questions answered. And so right off the bat, we get another question, which is, would this be an outpatient procedure? Where is this performed? And what insurance doesn't do? I guess what insurances don't cover the device? So I know that's a lot of questions, and he tried to get 3 in for one, but I'm not surprised. So if maybe we can start with the first question and see how we can be able to deal with that. And then we have a few more that are coming in pretty quickly. So I'm gonna let you guys jump on this, and I'm gonna let you be center stage.
No question, outpatient procedure. The patient will be in and out relatively quick. The procedure can be done in a variety of different places. Usually in at times hospital setting, outpatient surgery center. And if I'm okay talking about it, Dr. Landrum, obviously, there's some things that we're trying to do to make this more accessible in the office as well.
Yeah, just to add on to that too, I think the really cool part about this product in particular is that not only is it an outpatient procedure, but 99% of the time we're able to program the stimulator the same day that it's being implanted. So the patient get to go home that same day getting some sort of relief. So it's not like something where it's implanted. They have to sit a couple weeks, wait for it to heal up before they start using it. They're using it immediately after 99% of the time.
Hey, guys, to that end, I actually want to pose a question to you because I know this could be confused really quickly with spinal cord stimulation. And I know you guys are very familiar with spinal cord stim. And we have a few more of those questions to answer within this, and there's more coming in rapidly. But one of the things that I'm curious about is, can you define how this differs from spinal cord stim?
Yeah, absolutely. I mean, I worked in that space for a while, so I'll steal that question. So the main difference between this and spinal cord stimulation is that spinal cord stimulation is in the epidural space next to the spinal cord. So you're stimulating the nerves in that space next to the spine. This is a device that you're stimulating the nerves, really going after specifically at the source of where the pain is. I would say that's the main difference between the idea behind why and what you're doing. I would say the main differences between this from a product standpoint is when you're doing a spinal cord stimulation, you're typically implanting what they call an implantable pulse generator, and it's just a fancy word for a battery. The battery somewhat kind of looks like this, my little case, and is implanted underneath the skin. That is the power source. So the procedure, while still, I would say, correct me if you think I'm wrong, Dr. Landrum, still relatively, non-invasive. This kind of takes it to the next step. The only thing you're implanting for the stim router is the lead itself. So that's why Dr. Landrum makes an initial little poke incision, and that's really the brunt of the, of the procedure itself. Our battery is not implanted underneath the skin, so it's just a sticker, which just allows the procedure to be very non-invasive.
Exactly. So if I can kind of add to that so that we can be clear about this, if we're talking about doing epidurals, right, it's going to be inside like this. All right. If we're talking about doing this, it's going to be outside, out here. It's going to be one of the key major differences in terms of how we're going to address dealing with back pain versus how we would do it with spinal cord stim. There's value for both. Don't get me wrong. But I think that there's a difference between the two. And so I just want people to be clear about that.
Sure. And I think we see it sometimes where patients will call in and they'll be like, hey, I want the stim route. I was like, no, you don't. I was like, you just want whatever is going to help you at the end of the day, right? So there's a lot of patients that will come in and, we obviously just refer them out to, to physicians that use, a variety of different devices and modalities and things like that. But there's patients that come in and will say, hey, I have low back and leg pain, and it's on both sides and it's both legs and it goes all the way down to the feet. Those sometimes, are not the best stim router candidates because they're not specific pain patterns, right? So there are, like Dr. Landrum said, we see that where, just trying to find the best thing for the best patient. And then I did forget to answer the question for Jesse, the last one. And I like it because that's the way my brain thinks about what does not cover. So I'll give you the do not covers, right? And I'll try to quantify. Medicare is great. Majority of Blue Crosses are actually very positive. There is a national anthem policy. So if you have a national anthem, that has a negative policy. And if you have national Cigna, that has a negative policy. And then United Healthcare, it gets a little bit tricky. Outside of those, the coverage is very positive. And even with the local policies, with the local Blue Crosses, they typically have not followed National Anthem's negative policy. By the way, which is being fought on a consistent battle trying to get that overturned. But those are I would say that, the negatives, Cigna and then Anthem National.
All right. So we have another question coming in from someone else.
Yeah.
And I know we're going to talk a little bit about the process and we're going to get there in the next few slides or so. However, I think this was almost like you planted this person, but I know her very well. So what her question is the following: is there a trial done first?
Yeah, let me give you the, what's it called? Let me give you the Bioness answer, and then let me give you the Dr. Landrum answer, and then Dr. Landrum will trump me with his better answer. So, typically, in the stimulation world, there are trials done with Dr. Landrum specifically. He typically will do a peripheral nerve stimulator trial. That is you coming into the office and you being able to stimulate that nerve and to see if that nerve, what we call response to stimulation. And all that means to us is when we stimulate the nerve, let's say we'll talk specifically about the back area, right? In that medial branch. And we just did this the other day. You stimulate the area. Dr. Landrum puts it where he puts a little catheter there. We go ahead, we turn on stimulation in that area, and then we really just turn it back to the patient. And we say, hey, how does that feel? And if the patient gets a positive response, the patient can hang out in the post-op area for anywhere from 25, 30, 35, 40, 45, 50 minutes. Try the stimulation out. And if it's something that works well, they will go ahead and they will get it removed right there and then could be looked at scheduling the permanent implant, which will be the StimRouter product specifically.
Okay. So we have a few more questions, but I want to make sure that you guys kind of get through your presentation. So are there more things that you want to comment on in terms of as we get past the various different reasons or using certain language indications for why this might be viable? Are there other things that patients should know?
Tyler, anything that you're thinking about that you feel like I missed?
No, I think you did a pretty good job of the general overall scope of what we cover and why we're doing it.
Cool. Do we want to transition right into kind of the low back? And our plan was to really, break it down and focus on a couple different patient scenarios, and then, and then open up the questions for people that might, have that pain or have someone that does, someone that they might know that has that pain. So, when we're talking StimRouter for medial branch, it's very similar to what Dr. Landrum was talking about. This is specific for that low back area, whether it's on one side or on two sides or on both sides. I can tell you there's a couple different ways to do this, and the questions might come up, so I'll try to answer them as they pop into my head. There are different ways to use one sticker to power two different leads. So that is something that is no question feasible. There's also patients that like to have a sticker on each side. So there's a lot of flexibility, and it really depends on the way that you want to utilize your StimRouter. And Tyler and myself call ourselves your tech support nerds, because that's really just what we are. We're just guys that kind of sit behind the computer, work with a physician, and just make sure you're comfortable using your device. So there's a couple different ways to perform the procedure to allow you to use one patch for a couple different spots that you might get implanted, or use a patch for each single spot. So I'll let Tyler take the lead on the couple different patients that he specifically worked with. And
yeah, definitely. So for this first patient we're going to talk about, with the physician we work with that did this, she's out of Ohio State University, and Rams and I didn't know exactly what we were getting ourselves into when we were driving down there. That happens quite often, where we're driving to an implant and aren't sure what nerve is being targeted. And Rams called me and he said, apparently we're doing a medial branch. And I said, like a median in the arm? And he said, no, like a medial branch right off the spine. And I said, well, that's interesting. So we get there, and the patient that we're referring to is a 92-year-old patient, not necessarily a candidate for other more invasive procedures. He had Dr. Landrum, if you can go to the next slide, I think it shows really, really good just the extent of the work he's done on his lower back. Yeah, so you can see that dark shadowing there. That's all lower back fusion. So, and that's just some of the work. He'd had numerous procedures. There's a whole bunch of scar tissue in that area. So our physician at Ohio State just wanted us to try, or wanted to try this out, because worst case scenario, it doesn't work. Within the first couple of weeks, it's pretty easy to get that wire out. So if she figured if she could get it in place and get him some good pain relief with just that small incision that Rams was referencing, that may be the best option for him. So we actually went in and we did the first one side first. I believe we did the right side first. In a perfect world, we would have liked to have had that right lead kind of go straight down, just like it is on the left side. But as I mentioned, there's quite a bit of scar tissue in that area, so our tunneling tool was diverted slightly. The patient had such good relief that within a couple of months, we were able to go back in and get that second lead put in there as well. On the right side, this right picture, this is kind of illustrates what Rams was talking about, how there's several different ways that we can locate the patch in order to power these leads. So we're looking on the right side corresponds to that right lead that's off to the side a little bit in the left picture there. So what we can do, and what we did with this patient, because he is up there in years, his skin's a little bit more sensitive to the having the stimulation go through it, but we want to be able to give him stimulation as much as possible. So one orientation that we can have the patch on is in the one that's shown right there. That would be powering just his right lead. But then when he needs to give that side a break, he can go right into that loop that's on the left side of his scar there. So straight up and down and power that left lead. If both those areas are getting a little bit tender, there you can see a little bit, there's two horizontal lines in the bottom of that picture there. You can actually just twist that patch. And it's a little bit less efficient. I don't want to go too much into why, but if we're only covering those receiving ends, we're able to still generate stimulation. It's just not quite as strong as when we're in these orientations where we're covering both ends of the lead. So by doing this, this particular patient is able to get stimulation and keep his skin fresh and ready. So when he has pain flare-ups, he has different spots he can go and try and breach those areas.
All right. So can I jump in on this? Is that okay?
Absolutely.
So as I understand it, because Tyler, you got fancy talk just like Ram. I don't know what's going on with you guys.
That's where I get it from.
Long story stuff.
I don't need to be a snitch, but
we put something underneath the skin. You pop a sticker on. You twist it one way. You twist it another way, and it can make your pain better because of how fancy this technology is. Is that kind of what we got going on here? I know it's way more complex with many millions of dollars spent to make this work. But from the patient's perspective, that's how simple it really is. No battery pack underneath the skin, like the two of you both said. Yep. And really, it's not as complex as what you might think. You get a little controller like you guys are going to talk about, and you can be able to increase the intensity, decrease the intensity, but it's not that complex. I know I have a lot of patients that are like, man, I don't even like using a smartphone. So I'm looking at this, and is this going to be something that's going to be really challenging? Am I going to need to put my stimulator in my grandkids' hands? I don't think so. So what we want to make sure is that people understand the simplicity and the elegance of how this can be able to provide value for problems that you thought you're going to have to use pain meds for indefinitely, or you're going to have to just tough it out and say, you know what, I just got to find a way to just suck it up and be okay with it. You don't need to do that. There are things that like this that can be able to provide value. All right, I'm going to get off my soapbox and let these guys talk.
Guys, and Tyler, that's my fault too. I do really want to just touch on that really quick, what Dr. Landrum said, because I get that question a lot from patients. This is the device itself, and you see the buttons that are on the screen right now. These are the only buttons that are of any importance. The top button turns it on and off. This wavy button starts and stops the stimulation. These are plus and minus arrows. Whenever you want the stimulation stronger, you hit the plus. Whenever you want the stimulation decreased, you hit the minus arrow. It's as simple as that. And I would say too, from how often or how much you use the stimulator, that really is up to each individual person. If you have pain all day every day, you can utilize it that way. if the pain's more in the morning or more at night or more when you walk or more when you garden, you know, whatever it is, you can kind of use a stimulator however best suits your life. You're kind of the boss of it after you get it and know that it can help manage some of your pain. I'm sorry, Tyler, go ahead.
No, perfect. We could go to the next slide, please, Dr. Landrum.
Well, before we go to the next slide, Tyler, we're going to
Sure.
need to take a quick break in order to be able to kind of give a pub to our channel, which is Cutting Edge Pain Relief. And we'll be back to tell you about the second patient, how they benefited, and how you can benefit too. All right, so we're back with Rams and Tyler talking about Bioness stim router specifically for back pain and how that there's actual treatments out there that can be able to provide value in multiple different ways. And specifically, we're talking about Bioness stim router used for medial branch nerves. And so I'm going to get back off the stage, let them get center stage, and let them talk further about patient number 2.
Perfect. So patient number 2, very similar to patient number 1. They weren't quite as old, but they didn't necessarily want to undergo a more intensive surgery. It was a personal preference of this patient. Her pain was a little bit higher up than what we usually see, specifically categorizing as low back pain, but we were able, our physician at Ohio State was able to identify the level where her pain initiated, and by doing a local anesthetic block. And from that point, we were able to move forward with knowing where we wanted to put the actual wire and where we wanted to put the patch based on placement of the wire. So we can go to the next slide, please, Dr. Landrum. All right, so this patient, you can see again here, we have the wire where it's shown under fluoroscopy on the right-hand side. That top part of the wire is the nerve where the contacts are interfacing with the nerve that was giving her pain. And the bottom part of that wire is our little receiving end that talks to the patch that Rams went over previously. And then on the left-hand picture, you can see where our patch ended up being placed based on that. So she had to get a couple different pokes for this one just because there were some different sensations that the patient was feeling. So we wanted to make sure we were in the exact right spot. So that's what that little poke is there. But that top blue arrow is corresponding to the top part of the wire in the right picture there. And then the bottom of the patch corresponds to the bottom of that wire there. And this patient only had the pain on the left side. So we only ended up doing the one. I think at one point she was talking about doing the right side, but because the left side started to feel so much better, her right side started to feel better. And that's something that we see pretty frequently too, not necessarily with just back pain, but other peripheral nerves where you may think there's 4 or 5 things going on, but once the primary issue gets fixed, it kind of alleviates the pain and from compensating from that pain in the other areas as well. So that's what we've seen with this patient in particular. And I actually just had the opportunity to see this patient yesterday. She's about 15 months post procedure, and she's still doing very well. She she has these little spasm episodes, or she used to, where she can now she can feel the spasms start to come on, and she'll just put her patch on and start running a program, and she can generally stop before she calls them an explosion, before an explosion of pain comes on. So she's been able to mitigate those. She doesn't have those nearly as often anymore. And yesterday I was trying to just tweak some things to see if we could get that from ever happening at all. So we'll see how that works out. And I'll have Dr. Landrum give everyone an update so I know how that programming went. And then this patient started at an average pain score. So every day she was getting out of bed with a 7 pain score. And now she's down to a 0. Some days it gets up there to a 2 when she's really active, but most days she hovers right at 0. So
All right, guys, is there another portion of this slideshow that you guys wanted to talk about, or is this pretty much most of the patients that you want to have a discussion about right now?
I think these two are pretty good summary of what we generally see. We've done several more, but I think a lot of them are just going to be repetitive from here on out. A lot of the why we want to do this procedure in this specific area, and a lot of the outcomes have been pretty similar. So we don't want to get too repetitive, repeating the same story. But yeah, I think that's a pretty overall generalization of the results we've seen and the kind of patients that benefit from this procedure.
Okay, so we got a number of other questions that are coming up. And so I believe there was one question that was asking about how can you determine if your foot pain is caused by nerve compression from the spine? So I'll take this one. I think that's really going to be an evaluation by your physician and them having an understanding that it can come from multiple different places. If I was using the Bioness stem router language, I'd probably say multifactorial. But in terms of using it like regular people, is that it can come from a lot of places. It could be in the foot, it might be in the ankle, maybe it's coming from the back. And so we have to kind of bring a combination of things like examination, imaging, maybe some different diagnostic tests, like something that's called an EMG, of nerve conduction study, to be able to evaluate it. If your doctor is really fancy, they might do a small fiber biopsy. Some of those type of things can be able to give insight and understanding about whether that is truly nerve compression or whether there might be some other things that are causing that issue. Okay, so I think I just lost Tyler for just a quick second, but we're going to keep pressing ahead for the time being. And so one of the questions that has come up is, what's the battery life expected to be, or is it rechargeable? And I think this is really interesting because I think you'll be able to answer this with a fair amount of aplomb.
How did I miss that part? They're both rechargeable components. There's a lithium-ion rechargeable battery. So whenever you're not using, you just toss on the charger. We usually tell patients to charge it every night whenever they're not using it. And then they can really get usage out of it the whole entire day, however they use it. Even if they use it all day, every day, they'll be able to get through that day on that single charge. Then when this is a little sticker too, to answer possibly another question that might come our way. Whenever this gets unsticky, you just pop it off, and then you bring another sticker, and you attach the other sticker on.
Bada bing, bada boom.
Yeah, and I removed the fancies out of that one, Dr. Landrum. That was.
I appreciate it. All right, so we got another question that's come in. Is, does it stimulate all the way up the catheter or just at the tip?
So that's a great question. So the little sticker sends a signal to the actual, what we call the receiver. That's the part that's tucked right underneath the skin, kind of at the top level of the skin, right underneath. And then it grabs that signal that it got from the sticker and it delivers it all the way down to the contacts that are laid next to the nerve. The most important part of what we're stimulating is the nerve itself. That's what we want to be stimulating. We don't really want to be stimulating the other stuff. we want to be stimulating where Dr. Landrum puts those contacts, that he's going to put them next to the nerve. And that's what's going to give the patient the pain relief, is stimulating next to the nerve. So think of it as kind of like a pathway that we create, right? The patch talks to the lead, and then it delivers the current all the way down to the nerve, to the contacts that Dr. Landrum's laid right next to the nerve.
Okay, so I'm going to pose some questions for our patients because I know that they have some interest in. So you've been able to do a trial and get some degree of insight about what's going on. What's the major thing that the patient has to do in order to get the permanent, if anything?
Are you asking from an insurance standpoint, possibly?
I'm asking from just a patient standpoint. The trial worked, and so now what do you have to do?
You schedule the permanent implant.
There you go. Exactly.
Schedule the permanent implant.
And does that need to be done in a hospital per se?
Per se, no. The way we're working it out is, for it to be done, especially with the invasiveness of it, for it to be available for patients to be able to do in the office.
That's incredible. That's very incredible. Okay. So what other things do we need to know about this treatment option and how it can be able to help people? Is this something that might be short term, or is this a longer term offering?
I'll answer this, and then I'll let Tyler add his 2 cents to it too. I would say the majority of our patients, let's say they come in and they say, hey, I have pain all day, every day. When they get their stim router, they're most likely going to be utilizing their device all day, every day. What we've seen, and there's some pretty nice data, but we see this, with our patients that we work with on a daily basis, is that for the first 60 to 90 days, as you begin to use your stim router relatively consistent, a lot of patients seem to be needing their stim router less after those 60 to 90 days, that their pain doesn't seem to be coming back as aggressively as it was before they got the stim router. So I would say that patients will use it initially, the majority of the day, and then a lot of our patients really transition into utilizing it for possibly a couple hours in the morning, couple hours at night, and we have some patients using it every other day. We always say this. We say, hey, doctor's going to put it where it is, where we need it. We're going to program it. And then we're going to let your nerve respond to the stimulation and see how often you need it. But what we've seen with patients is the more you use it initially, then less and less you're having to use it long term. Tyler?
Okay.
Agree 100%.
Yeah.
Tyler got in quick. All right. He's not going to get me this time. All right. So to that end, let me kind of flesh that out just a little bit further, make sure that we got this 100%. So basically what I want to know is this something that will only be in place for 30, 60 days in terms of the lead, or is this lead something that can stay there for a while?
So the lead is designed to be implanted indefinitely. So that can stay in permanently. What Rams was referencing with patients using it less and less, I think that's really important, that they can use that battery. So say they don't need to use it every single day anymore. They can tuck it in a closet, and then say a few months goes by and something happens where that pain flares back up again. They can dig it out of the closet, plug it back in, throw the patch back on, and use it again. So the wire is designed to stay in permanently, yes.
And that's something that's pretty unique about you guys' company and how we are approaching this treatment for pain, is that it can be adaptable. It can be flexible for the element of the patient so that they can be the one that drives it, and it's not just based on a time duration of a specific point.
Yeah.
So I think that there are some more questions that are continuing to come in, and I think I probably feel the next one, and it is, would this device also be used with pain medication or without? And I think much like anything else, it's going to depend on the patient and the person, right? So ideally, we would love for this to do what it did in those other patients and take the pain down to zero, right? And if that's the case, then perhaps we don't need medication. We can be able to stop it completely. But is this something I think has a contraindication to medication one way or the other? No, I don't believe so. So could you possibly use this as medicine? Yeah, but our desire is to see if we can be able to have to stop that pain medicine, much the same way as we hope to stop the pain and really be able to kind of kick that pain, punch it in the face, and be done with it. So, guys, I have a question about the aspect of this back pain. What would you, if I was going to use a Rams word or Tyler word, say are the main indications for the back pain stimulation? When would that kind of pop up? Is it more for someone that has a muscle issue, that has a joint issue, that stays in the back? Anything in particular that you could allude to?
I would say our patients have been pretty diverse in what their chief complaints of where their pain is. Some of them have been very localized, right to the spinal column and in that area. We've had some where the pain seems to start kind of in like the top of the buttocks and go out towards the hip a little bit, and we've been successful there. So I don't think that there's any specific indication, as it were, for what we're looking for when we go into this. Pretty much anything that can be helped out by a nerve block, we would like to see how a stimulator would help that patient as well. But I don't think there's anything that we're specifically looking for.
Okay. And then we have another question I think is a very astute question that has come in, and I think is also another distinguishing point between this and some other products on the market, and that is the following. Is there a risk of infection the longer it's in?
So I'll take that one. And I would probably give the reasons for our lack of infection rate, mostly because of what we're implanting, the size of what we're implanting being very small, and then the incision being very small, and the procedure time. I know we didn't get too much into that. Is 30 minutes plus and minus 15 minutes. So it's a relatively quick procedure. But during our clinical trial, there were 0 lead migrations, which just means the lead didn't move, which is positive because we don't want it to move once it's in place. And then there were 0 infections during that about 150 patient clinical trial. So very positive things from that side of things.
Right. And so I know you guys can't speak off label, so I'm going to speak off label for you.
Yeah.
And I'm going to mute you guys both so that way you don't have to have any issues with commenting on this. But there's another product out there that definitely has value. However, one of the things that it does is it stays in for a number of days, and it has an externalization, which basically means that lead sits outside the skin to an extent. And although it also has not had any degree of infections that have been seen in either the elements of the studies or it being utilized in practice, one of the questions that has come up frequently is it a possibility? For all the language that has been put out there, it's been said that no, that's not the case. But for those who are in the industry who've done neuromodulation studies, there have been questions about if you have something externalized to the skin, is it a possibility? To date, we haven't seen that with either of the two. But what we have concerns about is if you're not buried and it's not under the skin like a pacemaker or other piece of surgery, that you would have something to prevent it from the various different things that we have on the skin, no matter how clean you might be, is could there be some possibility of other challenges that might occur? Again, to be clear, there are not and haven't been any infections that have been documented for this or any other device, but I know that those are questions that are frequently raised by both patients as well as physicians. Okay, so in coming to this, I really appreciate you guys being here to talk about a new type of technology that is continuing to show improvement in pain and being more and more minimally invasive, meaning we're not having to do as much of an incision. We're not having to have this be a long procedure. We're not having to go quite as deep for treatments and such. Is there anything that you guys would like to add as kind of a follow-up?
No, I mean not from the, you know, I think questions sometimes come up. So, you know, I know Dr. Landry obviously has our contact information, but if anyone ever has any questions, you know, device related, obviously if they're, you know, medical related, we'll obviously always throw those back at Dr. Landrum. But if there's ever any, you know, anyone that, you know, has questions specifically on the device that come up, obviously after this, we're more than you know, we're more than willing to, you know, take calls. We're driving a lot, so it's usually patients or our wives that will call us. So we're more than happy to take calls as questions pop up. So
All right. And so to that end, I got to give credit to my guy. So as I understand it, you are waiting and expecting another addition to your family. Is that right,
yeah,
Rams?
I heard a scream downstairs. I was like, does that mean? Yeah. So my wife is full term. We are expecting baby boy number 3 any day now. So if it was up to my wife, it would have been 2 days ago. So she is for sure ready to go.
Well, early congrats and all the best. I appreciate you joining us. And when I know you were concerned about whether this is going to be a good time for you or not, I thank both of you guys for being here. It's always a pleasure. And we really appreciate the things that you do with patients and how you're able to provide an improvement in lifestyle and quality of life.
Thank you so much for having us. We appreciate it.
So for those of you who are new to our channel, I just want to kind of tell you, if you enjoy topics like this, we really want you to be connected to our newsletter. So really what you want to do is to go to cuttingedgepain.com/newsletter and register so you can be informed about these topics as well as some other things that we do. In addition, I'd also say if you want to be able to watch this video again, one of the things that you want to consider doing is being able to go to our YouTube channel and sign up. And that YouTube channel is Cutting Edge Pain Relief. And you can be able to see this and a number of other videos, like we just talked about upper back pain. And there's a video that talks about scapular pain and how it's different. And then one of the last things that I would say is that we actually are going to be doing a video that won't be on either Facebook Live or on YouTube. So you really want to kind of keep that in your calendars and take a look for it, which is going to be coming out on the elements of March 4th. And you want to sign up for that and be able to make sure that you're part of that. And what you really need to do is go to this www.tinycc Dr. Landrum Pain webinar. And we're going to be talking about this for a select few that really want to have an understanding about different ways to be able to treat pain. As always, we appreciate those of you who are able to join us live, as well as those who catch this later. And what we really want to be able to do is to make sure you know your options for pain relief so you can be able to figure out how to be able to punch pain in the face and get back to leading the life that you deserve. Thank you so much.